So longevity medicine in this context is about early risk identification, proportionate intervention, and preserving function, instead of reacting once pathology is established. Life is good. We are living in the most energy-abundant environment in human history. There's constant access to ultra-processed food, refined carbohydrates, and fructose, and this has created a profound mismatch between our evolutionary biology and modern exposure. Crucially, metabolic dysfunction often precedes obesity and not the other way around. Many individuals develop insulin resistance, ectopic fat deposition, and chronic inflammation many years before meaningful weight gain. The visceral fat around our organs is not inert. It's actually an active endocrine organ, and it produces inflammatory chemicals called adipokines that impair insulin signaling, mitochondrial function, and vascular and musculoskeletal integrity. And this explains why metabolic syndrome, fatty liver disease, cardiovascular disease, and OA so commonly coexist. Fructose plays a distinct role here. Unlike glucose, it preferentially drives hepatic fat synthesis, or what we call de novo lipogenesis, as well as uric acid production, and this worsens insulin resistance at a cellular level. From a longevity perspective, the key message here is early detection. We need to get in there while these processes remain reversible. Metabolic dysfunction-associated steatotic liver disease, or MASLD, previously termed NAFLD, now roughly affects 1 in 4 adults globally, and it's comparable to alcohol-related disease, which is more in decline. It is frequently silent. Liver enzymes may remain normal until late stages, and that makes it a poor screening tool in isolation. Importantly, MASLD reflects systemic metabolic dysfunction rather than isolated hepatic disease. You can see this progression with the liver function tests remaining normal all the way up to the point of irreversible liver fibrosis. And the challenge here is that most patients are diagnosed late when the fibrosis is already present. Fibrosis represents collagen deposition and architectural distortion in the liver, still partially reversible in the early stages, but increasingly it's fixed as it progresses. Excess energy, particularly from refined carbohydrates and liquid fructose, is initially stored safely in our subcutaneous fat. However, this storage capacity is genetically constrained. Once it's exceeded, lipid spillover occurs. Now, while subcutaneous fat does act as a store, a protective store, as a buffer, the visceral fat can lead to inflammatory chemicals being produced that increase cardiometabolic and neurodegenerative disease. And this is why fatty liver should be viewed as an early warning organ sign, not a benign incidental finding. Fat accumulates in tissues that were not designed for storage. It gets into muscle, and once it's in muscle, it damages insulin receptors and impairs the normal processes for partitioning of fuel and insulin signaling. The liver then starts to accumulate fat. That's what results in MASLD that we've talked about. It increases its output of particles called VLDL, and it also then has effects on the pancreas and its insulin production too. The development of fat around the heart, the liver, and even the vessels can result in vascular disease that even affects the brain. And it's important to realize not all obese patients are metabolically unhealthy. And in fact, not all lean patients are healthy. In fact, up to 40% of normal weight adults demonstrate visceral adiposity and insulin resistance. The BMI just fails to capture this. And this is why whole body DEXA assessment of visceral fat is the gold standard, and it's the first step to a comprehensive assessment of metabolic health. From a sport and exercise medicine physician perspective, metabolic dysfunction is a major but under-recognized driver of chronic musculoskeletal pain and osteoarthritis. We see chronic hyperglycemia, and it promotes a process called non-enzymatic glycosylation of collagen, forming advanced glycation end products that stiffen the tendons, the cartilage, and the ligaments. And this impairs load tolerance, shock absorption, and tissue recovery. In parallel with this, insulin resistance and visceral adiposity amplify the inflammation signals, particularly through adipokines, and particularly in the presence of fatty liver disease. These enzymes that break down our soft tissue matrix, called matrix metalloproteinases, are upregulated, and that accelerates cartilage and tendon degradation, as well as synovial or joint inflammation. So this explains why we're increasingly seeing osteoarthritis and tendinopathy in patients with fairly modest mechanical loads but significant metabolic dysfunction. And our role as SEM physicians now has to extend beyond managing joints. It includes addressing those upstream metabolic drivers through exercise prescription, body composition optimization, and insulin sensitization strategies. And when this is done well, pain, function, and overall metabolic health all improves. Insulin resistance is best understood not as early diabetes, but as an adaptive response to chronic energy surplus. The key point here is that insulin resistance and metabolic dysfunction start in the muscle. Skeletal muscle is the largest disposal sink for glucose in the body. Excessive lipid deposition within muscle fibers, particularly diacylglycerides and ceramides, disrupt the insulin signaling in muscle. The pancreas then compensates by increasing insulin output to try and maintain normal glucose or normal glycemia for years. This compensated hyperinsulinemic phase can persist for a decade or more, and during that time, the visceral fat increases, hepatic triglyceride storage accelerates, and vascular risk silently accumulates. So muscle insulin resistance is not a late phenomenon. It is the first domino in metabolic disease. It drives downstream liver, lipid, pancreatic, and even cerebrovascular pathology. The classic work by Gerard Schulman and his colleagues over the last couple of decades has demonstrated that young, lean offspring of individuals with type 2 diabetes already exhibit skeletal muscle insulin resistance and what's called intramyocellular lipid accumulation, muscle fat, before glucose abnormalities emerge. And clinically, this reframes insulin resistance as energy toxicity. Importantly, it's a reversible state when the underlying drivers are addressed. Postprandial insulin responses provide early insight into metabolic health. We see a spectrum. We've got a normal rise and fall here in the green, mild exaggeration, marked exaggeration of hyperinsulinemia, and then this prolonged, exaggerated response to glucose with the elevated insulin. And these responses often precede fasting glucose abnormalities and strongly correlate with visceral fat burden, hepatic steatosis, and future diabetes risk. Chronic high levels of insulin or hyperinsulinemia is not benign. It promotes lipogenesis, inflammation, appetite dysregulation, high blood pressure, and progression to MASLD. Understanding insulin dynamics allows earlier and more precise intervention well before traditional diagnostic thresholds are crossed. We want to get in there before people have a diagnosis of diabetes or even pre-diabetes. Metabolic dysfunction progresses along a predictable continuum. Here we have stage 1, optimal metabolism, there on the left. That's where we have normal glucose, insulin, and metabolic flexibility. Across to phase 2, where we have early insulin resistance, rising insulin, worsening triglycerides and HDL, increasing visceral fat, of course. Then we end up with compensated hyperinsulinemia in phase 3, where people have normal glucose again, but rising long-term measures of glucose and spikes of glucose after meals. Stage 4 is where we end up with systemic inflammation and endothelial dysfunction affecting the cardiovascular system. And in stage 5, we have frank, overt diabetes, cardiovascular disease, macrovascular and microvascular complications, and hepatic steatosis. And importantly, glucose remains normal through most of these stages, which explains why standard screening can give false reassurance. Also, in stage 5, it's worth noting that it is at least partially reversible with lifestyle and medical intervention, so we don't just give up on people who are at the end of this metabolic spectrum. Early detection requires moving beyond glucose alone, clearly. Some useful early phase markers that we utilise include fasting insulin and HOMA-IR, triglyceride to HDL ratio, apolipoprotein B, which we've mentioned is an important marker for cardiovascular disease, DEXA-derived visceral fat, and we also use ALT as a late supportive marker, although it isn't always immediately visible. At an organ level, for further clarity, we sometimes perform a liver ultrasound or fibroscan or even an MRI of the liver. We perform an OGTT with insulins and a CGM if people need to know what their metabolic flexibility is. And when this is all integrated with clinical history, exercise tolerance, body comp, metabolic dysfunction is measurable and visible. BMI is one of the weakest tools we have for assessing metabolic health. Frankly, it confuses people. Individuals with identical BMI can have vastly different visceral fat burden, liver fat, insulin sensitivity, and long-term risk. The visceral fat drains directly into the portal circulation of the liver, driving hepatic insulin resistance and problems with lipids. And this explains the common TOFI phenotype, the lean appearance with high metabolic risk, thin on the outside, fat on the inside. And clinically, risk assessment has to occur at the organ level, not superficially. One of the most powerful relationships in longevity medicine is the inverse association between cardiorespiratory fitness and liver fat. VO2 max demonstrates a clear dose-response relationship with hepatic steatosis. Increases of approximately 3 mL per kilogram per minute are associated with 20% reductions in liver fat independent of weight loss. So this isn't just association. We can see that exercise directly alters, and fitness directly alters, hepatic metabolism, insulin sensitivity, and the way our body handles lipids. Fatty liver strongly predicts future diabetes, cardiovascular disease, and accelerated biological aging. As much as dietary intervention is critical, it's another reason why improving fitness is a core therapy in metabolic medicine. Fructose is handled almost entirely by the liver. Dr. Robert Lustig's work on this over the last few decades has exposed the significant harms to our society and particularly our children. High fructose intake, particularly from soft drinks, juices, smoothies, and processed foods, overwhelms hepatic metabolism. Fructose uniquely bypasses glycolytic regulation and it drives de novo lipogenesis, it consumes ATP, generates uric acid, and it rapidly increases liver fat. The liver responds by exporting triglycerides as ApoB-containing VLDL particles, and this worsens cardiovascular risk and promotes systemic insulin resistance. And this isn't about demonizing whole fruit, which is well balanced by its fiber content. It's about recognizing that liquid and concentrated fructose uniquely stress the hepatic metabolism. The research is clear that reducing fructose exposure is therefore a core strategy in reversing metabolic dysfunction. But interestingly, hepatic fat is dynamic and highly responsive to intervention. Diet quality matters as much as calories, as we can see from this crossover trial from Ryan and colleagues. It showed that individuals that switched between a Mediterranean-style diet and a low-fat, high-carb diet, despite their similar calorie intake, showed intrahepatic lipid fell significantly more on the Mediterranean diet, and it rose again when participants swapped over to the other diet. This highlights that macronutrient quality matters just as much as calories for metabolic-associated steatosis reversal, largely through the effects on insulin sensitivity and hepatic de novo lipogenesis. Now, on the right side, we see the results of Newsom's study on the effect of semaglutide, also known as Wegovy or Ozempic. What he did was, over 72 weeks of the use of this medication, they tracked liver enzymes, and they found reduced inflammation, improved hepatic insulin sensitivity, not just weight loss. So this trial demonstrating meaningful histological resolution of fatty liver in a substantial number of patients, but the fibrosis stayed stable. It didn't improve in either group. Now, the clinical implication is clear. MASLD is an early modifiable progression of systemic metabolic disease, and it should be treated actively, not observed passively, because otherwise we'll end up with fibrosis, which is mostly irreversible. After everything we've covered here, insulin resistance beginning in the muscle, liver fat accumulation, fructose-driven fat overload, and the progression toward MASLD, the key message here is this. Metabolic dysfunction is highly reversible, particularly in its early stages, and if we can really utilize this cellular energy signaling protein switch called AMP kinase, we can alter the master energy sensor in the body. When AMP kinase is activated through exercise, caloric control, fasting, or reduced energy availability, it shifts physiology from a storage state to a utilization state and a repair state. It increases fat oxidation, fat burning, it improves mitochondrial efficiency, enhances muscle glucose uptake, reduces liver fat, and suppresses excessive mTOR signaling. AMP kinase activation counteracts the biochemical state that drives insulin resistance and MASLD. Importantly, AMP kinase is activated upstream by these things: behavior, not medication. Structured exercise, resistance training, zone 2 aerobic work, reduction of refined carbohydrates and fructose, a protein-dense whole food diet, sleep optimization, and alcohol reduction all converge on this pathway. These interventions and the behavioral coaching that go with them reduce liver fat, restore insulin signaling, and restore metabolic flexibility. So while our genetic predisposition varies, our metabolic health remains highly modifiable when an approach that's taken is holistic and sustainable. The longevity program at PSM operationalizes this biology. We measure organ level fat, VO2 max, insulin responses, lipid patterns, and metabolic flexibility. The interventions are then personalized, proportionate, and they're modified longitudinally. When applied early, aligning exercise, sleep, nutrition, and metabolic health is our number one most powerful tool for preventing MASLD, type 2 diabetes, cardiovascular disease, joint and tendon dysfunction, and accelerated biological aging. This content is for general education only and is not medical advice. Individual risk and treatment decisions should always be discussed with your own doctor. It is not intended to be medical advice, doesn't replace consultation with your doctor, and should not be used to make individual health decisions. Metabolic risk screening and treatment decisions depend on your personal medical history, family history, and individual risk factors, and should always be discussed with a qualified health professional. No patient-doctor relationship is formed by viewing this content. If you have symptoms or health concerns, please speak to your GP or treating specialist.